Welcome to the Obesity Medicine Podcast with your host, Dr. Matea Rentia, board certified in internal medicine and obesity medicine. Here, we talk about a path to metabolic health, and we have real conversations about chronic weight management and living a full life. Just a reminder, I am a physician, but I'm not your physician. So everything that's on this podcast is for informational purposes, but please go talk to your doctor about what's right for you. There is no medical advice being given on this podcast. Welcome back to the podcast, everybody. I'm so excited. We have Dr. Sabrina Huq on. She's an amazing endocrinologist that I have now known for a little period of time, but oh my gosh, is she knowledgeable? And frankly, when I was seeing more of the work that she was doing, I really was like, hey, can you come on the podcast? Because I think that there are a lot of endocrine conditions that I'm going to say specifically women, not that men are not included in this conversation, but for women today is who we're going to focus on with PCOS. I think that's just a really misunderstood area. Can we start out with you just briefly introducing yourself? Tell us about your clinic a little bit, how you help people, and then I have so many questions for you.
Sure. Sabrina Huq, I'm an endocrinologist. So I see adult patients, and I'm also board certified in obesity medicine and internal medicine. And I also do a lot of menopause treatment. I'm originally from Bangladesh. I can't pronounce it any other way. It's a little country near India, but I grew up in Middle East in Abu Dhabi. And then I went for medical school to India, and then I came here. I did my residency in Montefiore, Bronx, and then my fellowship at Henry Ford in Detroit. But I love New York. I love the diversity of it. And because I speak multiple languages, it's where I feel like New York City is as diverse as I am. My clinic right now, it's a adult private practice in endocrinology. I see a lot of diabetes, PCOS, obesity, menopause, and I use a lot of continuous glucose monitor in my patients. And I feel like that gives me a lot of information that is also helpful for my PCOS population. Overall, I've been very privileged. I learn from my patients every day, and I think we are able to make some real difference in people's lives.
Oh, thank you for that introduction. I did not know all this about you. And I find that when you have all these experiences, what we know is so much better at the end of it. I want to shift gears to talking about PCOS. Can we start out with you just first defining it? Because I think that people really don't understand what it is.
PCOS stands for polycystic ovarian syndrome. The name's not really accurate because we get the impression that we have to have multiple cysts in our ovaries. And also, what we're looking for is not really cysts in ovaries. We're looking for multiple immature, underdeveloped follicles. Mm-hmm. And the follicles have to be a certain quantity, but the name is not really accurate because someone does not have to have a pelvic ultrasound to get a diagnosis of PCOS. And even if someone does get the pelvic ultrasound, they don't actually have to have the cysts in the ovaries or the immature follicles in the ovaries. Mm-hmm. So the name can be misleading in that way. But because of PCOS terminology, the name has been very commonly used. It's still being used often. What it really means is we want to make sure that someone meets 2 out of 3 criteria and that we rule out other hormonal issues. So the 2 out of 3 criteria is number 1, irregular periods, and also clinical signs or blood tests that show excessive male hormone levels. Female patients have male hormone levels, all females have male hormone levels, and males have female hormone levels, but we don't want to see excessive amounts of male hormones in a female body. We also look for the pelvic ultrasound. If it does show the multiple follicles, then that counts towards the diagnostic criteria, but it doesn't have to be present.
Okay. Can a woman have PCOS if let's say that we don't have the ultrasound and they don't have irregular periods? Is there still a version that they could have?
Yes, that's a really great question. So we want to think about what normal periods are. So when a girl hits puberty, we start off with breast development, and within 2 years of breast development, we would expect a normal puberty girl to start having periods. So if a girl does not start having periods 2 years after breast development, then that's something for moms to bring up to their physician, or that's something for the teenage girl to talk about, to bring it up as something to be concerned about. Early teenage years, we should not be labeling someone with the diagnosis of PCOS because it still takes time for the menstrual cycle to mature. It can take up to 8 years, actually. So we have to make sure that it's an adult female patient that we are seeing for PCOS before we label them as such. So probably late teens, early 20s, we can be clear on the diagnosis.
Okay, that's really good information because I feel like I know I don't see kids. So maybe that's why I'm like, oh, great to know. Because I feel like I'm seeing girls online at a really early age being like, I have PCOS. And I'm sitting there like, you're 14. How are you saying that right now? So I think this gives us some really good context.
Yeah, and it's always good to know what normal periods look like so that we know what an abnormal period should look like. Normal periods, the cycle length is usually about 21 to 35 days, and each person has their own type of normal for them. Let's say for someone, they're getting their periods every 30 days. That means every 30 days, within 2 to 3 days of that 30 days, you expect to get your periods. So it cannot be 21 days, 1 month, and then 30 days the next month for the same person. For the same person, the period cycle length should stay constant. There are a lot of great apps that are present nowadays. I use FLO, that's Flow. That's the one that I recommend to my patients. You don't need a super complex version. You just need to keep track of your cycles from month to month. And I think of it as like a vital sign. Like when we take blood pressure, when we take height, weight, keeping track of your cycle length is your vital sign that you keep track of. And this will help you in your teenage years. This will help you when you're trying to see whether or not you have regular periods. This will help you when you try to conceive, when you try to plan a healthy pregnancy. And this will also help you during perimenopause and menopause.
Yeah, I love that you bring up the full arc because I find that when women want to get pregnant, now they suddenly become concerned. Like now they're like, oh, I was never seeing how many days were in between periods. And I like what you're saying. You should actually always have an understanding of this just going forward. I know you said rule out other endocrine conditions. What labs do you think are super standard? Like we need these to understand PCOS and then this to understand that it's not something else.
Yeah, that's actually a very important question because nowadays in social media, we see diagnose yourself and then maybe we give the impression that you don't need to see a doctor, but it's super serious to make sure that you don't have scary things because scary things can happen. So, especially if you're missing periods, you're skipping periods for months and months entirely, it does increase the risk of endometrial cancer. And that can happen in younger patients too. So if you're going for months and months without periods, your uterine lining, the lining inside your uterus builds up and it's not supposed to be there. So those cells start changing. It can lead to bad things, especially if you have missed your periods for 3 months, for 4 months. Make sure you see your doctor before and you probably do have the diagnosis of PCOS, but it's also important to make sure we're not missing these rare issues. The other thing that we worry about, especially in endocrinology, is sudden change in symptoms. That means you're suddenly developing within a period of months, you're developing deepening of your voice, you're developing excessive hair that you had not noticed before. That could be something as serious as adrenal cancer. So we want to make sure that we keep an idea of the time frame. You want to make sure that you are seeing somebody before you self-diagnose yourself. We also want to rule out things like abnormal thyroid issues. We want to rule out excessive prolactin hormone levels. We want to rule out Cushing's syndrome in rare cases, but typically thyroid and prolactin. But we also want to make sure we're not missing the serious things like endometrial cancer and adrenal issues.
Yeah. Okay, that's so good. When you have diagnosed someone with PCOS, what are things that you commonly educate on that they need to know about having PCOS or just things that they might need to consider for the future? Like maybe we take the perspective that this person's like 20, 25 years old. Maybe they're not married yet. They don't have kids yet. Just giving a picture of what kinds of things would you be telling them about?
The earlier we diagnose someone, the better it is, and it makes the whole process a lot easier for patients. So PCOS at its core is multifactorial. Genetics can play a role, but genetics are not destiny. And epigenetics also plays a role. It's the environment that your mom was in when she was pregnant with you. It's your environment. Your dad's health also plays a role. It's your environment when you're growing up, how much endocrine disrupting chemicals you're exposed to, what kind of messaging you get, the stress. All these things do play a role. Metabolism plays a huge role in PCOS. So metabolism means anything that you take in from the environment. It includes food, the chemicals you're exposed to, the air that you breathe, the kind of population that you're exposed to. All these things play a role. And because so many things play a role, if we know which aspects to change, we can have a really good control of our health in PCOS. Ideally, I want anyone who's diagnosed with PCOS to know that if they can control their metabolism early on, they can have a healthy pregnancy. One of the biggest misconceptions that I see and one of the most common concerns that patients have is, will I be able to get pregnant? So if we diagnose someone early enough, they probably can get pregnant naturally and they probably will have a healthy pregnancy.
That's amazing. Let's say that they're having trouble, their blood sugar's starting to go up, insulin resistance, things like that. What kinds of things are actually helpful for them to look at as far as either lifestyle or medications, just all of it?
Yeah, first we want to take a look at whether insulin resistance is there. And we often think in medicine that it has to be in a flow chart way, but we're not textbooks. For example, I see patients with prediabetes without the lab tests showing insulin resistance. So anything can happen. We should not say that we should only check insulin, we should not check the HbA1c. We have to check a combination of things to make sure we're not missing something. Typically, I look for insulin resistance in the form of fasting glucose and fasting insulin. The HbA1c, the average hemoglobin A1c blood test that we commonly do. One thing to keep in mind is that if someone is having heavy periods or if they have iron deficiency anemia, the hemoglobin A1c may not be accurate. The other test that we do is we check hormone levels like testosterone levels. When we check testosterone levels, we also want to make sure that we get the free testosterone or the bioavailable testosterone because we really want to check if the active form of testosterone is abnormal. Sometimes the total testosterone can look normal, but the active testosterone is abnormal, and we won't really know unless we know that we have to look for it. The common thing that I see is birth control pills are very commonly used. But if someone is taking birth control pills or if they have any other form of hormonal contraception, then we cannot use blood tests for testosterone to diagnose someone with PCOS at that time. There's also a misconception that, okay, I'm on birth control pills anyway. What's the point in knowing whether or not I have PCOS? It doesn't really work that way. Birth control pills will probably not treat you fully for PCOS. And it's super important to know whether or not you have the diagnosis because you want to know that if you stop birth control pills, what will your testosterone levels look like? Will your periods become abnormal again? So definitely having a clear diagnosis is super important.
So what do you do with the labs if they're already on birth control? What approach then do you take to confirm it?
I ask patients to stop their birth control pill, but I always discuss with them. We always make sure we have a pregnancy plan in place. And I typically ask them to stop it for about a couple of months before repeating their blood tests.
Okay, that was like my next question. I was like, how many months? Okay, when you're saying fully get it treated, what types of treatment do you typically either you use or you see used often?
It depends on what their blood tests look like and what their overall health looks like. If I see signs of blood tests showing insulin resistance, like fasting glucoses, textbook is different than real life. Textbook is different compared to clinical practice, as you know. So what I look for is fasting blood glucoses. If I see them starting to creep in the 90s, that's actually a good sign that they're starting to show borderline diabetes, even though in textbooks we see 100 to 126.
I'm going to stop there for a second because that's actually really interesting because I feel like I'm so used to using the hemoglobin A1C and I do look at impaired fasting glucose in the morning, but I guess I just wouldn't say, oh, that this is the nine. I don't know. That's just really interesting. I always feel like it has to
Yeah.
break the 100. Yeah. Okay.
Yeah, and in our minds, because we read guidelines, so because we want to stay evidence-based, and we think of it as a finite number, but it's actually a spectrum.
Yeah.
So I look at it in different aspects and different angles. If I see fasting blood glucoses in the 90s, then I want to make sure that I get the oral glucose tolerance test, which is the 75-gram glucose lowering glucose test. And then we get the fasting glucose, give them the 75 grams glucose load, and then we check the glucose again in a couple of hours to see what the peak has been. Because oftentimes the glucose load or the postprandial glucoses start becoming abnormal before the fasting glucoses show up as abnormal.
Yeah.
And that makes a huge difference, especially nowadays with GLP-1s commonly in the market. Because if we see that the oral glucose tolerance test shows an abnormal glucose in the level of the diabetes range, someone can qualify for GLP-1 agonist medications. And that can be life-changing for someone with PCOS.
Yeah, I think that was something when the meds first came out because so many people were getting on them without labs because quote unquote, you didn't need labs before you started it, but then you really didn't understand how sick they were metabolically. And then they already were treated at that point. And so going back, let's say that someone was on a GLP-1, but they know historically sugars were high, but they never really got it confirmed. How long would they have to hold the GLP-1 to do an oral glucose tolerance test to have it be accurate?
I'm going to use the scenario of Nowadays, we start for pregnancy planning. We recommend patients to stop GLP-1s 2 months beforehand. So I would assume 2 months should be enough because GLP-1s, we know that it's dosed weekly, the more common ones, and 3 to 4 half-lives or 4 to 5 half-lives. So 2 months should be a good amount of time frame.
Yeah, amazing. All right. So you talked about how sick they are dictates what we do. So let's say that they are starting to have those impaired sugars.
Yeah.
What type of conversations do you have with the patient then, what you're talking about here, where the sugars are starting to be elevated?
This is my favorite part about seeing all my patients. I love starting from the basics. If it's diet, resistant blood pressure, obesity, PCOS, in our guidelines, we see how diet, lifestyle first, and then we skip that part and we jump to medications. Yeah. I like to go back to the diet and lifestyle, and I like to start with that. I've grown a lot as a clinician as I've been practicing medicine, and especially now with CGMs, continuous glucose monitors. What I started noticing was initially when I would practice medicine, I would give them a referral for a dietitian or nutritionist, come back, not much change, adjust medications, not a huge change. Yeah. But then what I started noticing is when I started doing the diet and lifestyle counseling myself, huge change in the CGM, glucose monitors, for both my PCOS patients, my diabetes patients, my weight loss patients.
Can I tell you, I had the same thing happen in my clinic because in the beginning, when I started my clinic years ago, I had dietitians and I thought, okay, they'll meet monthly with me and monthly with them. And then I realized they were only coming to me and I was like, wait a minute. I mean, if registered dietitians are listening, you are not all created equal. But what I learned over time was I was doing much more of it closely with them and we were getting so much further. So I love hearing you say that too, because it makes me not feel as out there with saying that.
Yes, and I would find myself begging patients, please go to the dietitian, please see the nutritionist. But it takes a lot for a patient to show up to the doctor's office. We don't make it easy.
Yeah. Oh, totally.
So I go over diet and lifestyle counseling. One thing that I see very commonly, most patients, probably 90 to 100%, my patients with PCOS often skip breakfast. Yeah. By skipping breakfast, what I mean, it might be coffee or it might be nothing. And that kind of sets the tone for the rest of the day. We want to focus on whole foods. So skipping breakfast, probably not a good sign of a healthy metabolism. So for a healthy metabolism, when you wake up in the morning or whenever after you've slept your longest period of time, you're supposed to feel hungry. You're supposed to have that hunger. Yeah. So you start off your day, have a good breakfast. The other thing that I talk to patients about is the difference between processed food and not so processed food. We all process food in some way. Just taking food, washing it, chopping it is processing, but we don't want ultra processed food. We don't want food-like substances in our diet. We want to eat whole foods in their whole form as much as possible. What I notice, especially because I have a lot of data with continuous glucose monitoring, is that whenever we eat liquid sugars or liquid carbs or liquid foods of any kind or anything that has been through a blender, like your smoothies, your green juice, your protein shakes, your milkshakes, insulin spike. Mm-hmm. Each time that insulin spike occurs, the excess insulin goes to the ovaries in our PCOS patients and it makes the ovaries put out more testosterone. So we want to make sure that we are eating whole foods in their whole form. Yeah. So it can be something like healthy carbs, like oatmeal, but the actual old-fashioned rolled oats instead of instant oats that has been like steel cut, not oat milk, because oat milk is not really oatmeal in its whole form. We want to really pay attention and really look into what's processed, what's not processed. We want to look at labeling. Processed food has a lot of marketing done on their behalf. I tell my patients to think about like the men and women in suits who are sitting in a conference room planning on how to make patients overeat on soda, overeat on diet soda, overeat the chips, how crunchy they are. It's a huge marketing industry that makes us eat and makes us crave all these processed foods that are actually harmful to us.
Yeah. I was talking to another physician friend of mine, and I was talking about how I find that physicians and therapists in the addiction space, I just find it fits so well with what I'm doing. And then we were talking about, that the food industry wants you to get addicted to the food. So it's like, of course, we need the same strategies to get off other substances that might be happening. Same thing with food. I wanted to ask you, what is a breakfast or two where you're like, this is a great combination, or maybe something that you like? Again, not that it's like perfect, but I always like to get your thoughts on that.
Yeah, I actually talk to my patients a lot about food. I never thought that I would be doing this when I started endocrinology. But for example, we want to think about a good lean protein with high fiber breakfast. So a balanced meal. Carbs are great, but carbs are great in combination with other foods. So if you want to do a quick breakfast, it can look like something like a half cup of oatmeal with some whole milk. If you like to drink milk, I would say avoid the 2% milk or the fat-free milk because those are more processed and it takes out the nutrition from all that processing. Half a cup of oatmeal with whole milk or with almond milk, not oat milk. And also you can add in some Greek yogurt. You can have your egg whites. You can add some chia seeds, flax seeds, berries, just whole food. And it doesn't have to be super complicated. It can mean boiled eggs that you boil the night before. It can mean just egg white omelets with a whole bunch of organic spinach, but doesn't have to be complicated, but you have to plan ahead. So you make it easy for yourself when you're in a rush in the morning.
What you're mentioning literally this morning, it was half a cup of oats, whole milk, frozen blueberries. So I'm like, what you're saying, and I do a lot of chia just like in water sometimes with meals if the fiber is not high enough. But okay, I love that you brought this up because it's simple, right? And also the fact that you're talking about using the whole products, because I talk to people about this too. People are always trying to get the lowest calorie Greek yogurt. It's like, yeah, but then you have no fats in it and you're constantly scrounging and feeling horrible. So we need you to actually feel normal. We need hormones to be regulated. So I love that you're talking about that as well. I have another question that seems unrelated, but I have a really nice person that wrote me and asked me this. I know you're going to probably not be a fan of it, but what are your thoughts about all these products where it's like, it's a peanut butter cup, but they put protein in it, right? I call them like Franken foods, but do you think it's okay, that's a better for you option? Or are you like, just don't even waste your time? What's your thought on that?
I don't have a hard and fast rule, really. I'm more like, okay, if you find yourself having cravings throughout the day, I want to make sure you're not skipping meals. Because if we're skipping meals, our brains and our minds, we're really intelligent. We're very intelligent beings. If we're not feeding our minds, we're not feeding our brains, then our brains and our minds, we need energy. So it makes us go out and eat food.
Yeah.
We want to make sure we're fueling throughout the day, we get enough protein. And then if despite that, you're still having cravings, you still want to eat something, have it, but have your whole meal first. Yeah. So have your protein, have your healthy fiber, and then have whatever you're craving. I'm not a fan of deprivation. I don't say never do this or never do that, but get your real food in first so you can feel like, okay, I can have this. I don't feel deprived. We lower stress. Stress does not help anything. Stress does not help any hormone.
Yeah. Definitely. It kind of reminds me of, I always say delay, don't deny, because once you have that whole based meal, you just feel different. You're not even thinking the same thoughts anymore about what you want. What are your thoughts on best times to exercise or certain things where you're like, I want everyone to do this? What are your thoughts on that?
Yeah, so a couple of exercises and exercise times that really help patients who are suffering from PCOS. One is after you eat your meals. The 10 to 15 minutes after you eat your meals is super important. So we want to make sure that you're not just sitting in one place, that you're not just watching TV, you're not just at your desk rushing, you're not falling asleep. Those 10 minutes after you finish eating, we just want to move. It doesn't mean going and running. It can mean just going for a walk inside your house, or it can mean if you're sitting at a desk doing some calf raises, pushing up on your feet, just doing some stretches. But any little movement counts, those 10 to 15 minutes after you finish eating. The other type of movement that really helps in patients with PCOS, insulin resistance, and other types of metabolic issues is weight training or strength training. Strength training does not have to seem very overwhelming. It does not mean going to the gym. A few of my PCOS patients, it's better nowadays, but it used to be like patients would come to me thinking that they would become bodybuilders if they start doing weights. But bodybuilders are very hard, right? No. It's a full-time job. It takes a lot to actually put on that amount of muscles. It's not easy. Yeah. So no one will accidentally become a bodybuilder or a weightlifter. The strength training that really helps is 3 times a week with 1 to 2 days gap in between, because our muscles have muscle memory. Our muscles remember the workout a couple of days, about 48 hours after we work them out. So it can mean doing planks at home. It can mean doing push-ups. It can mean doing squats. Push-ups can be from varying grades. We can use the wall, then we can use the desk, then the actual floor push-ups. But if you make strength training a part of your life, it can really sustain you lifelong.
Yeah. Do you have this is the minimum amount that I expect from you, or how do you do that with people?
Just 10 minutes, 3 times a week. Love and it. At home, start at home.
all the things you're saying, I'm like, I'm so glad I'm not wrong. I mean, I see it clinically, like I'm following the body composition, but exactly what you're saying. In fact, I just had someone earlier today and they were saying, I don't feel the motivation to. And I was like, first of all, you're never going to feel that. No one's like, yes, let's go
Yes.
do strength training. It's not
Yeah.
necessarily fun on the body, but it's interesting. I was looking at this study from a few years ago, and this can be like totally Captain Obvious, but they basically showed that people that had a routine, those were the only ones that really kept up with things because they had less decision fatigue, right? It was going to happen that time in the week period. They didn't need to like constantly redecide. And what I see with strength training is that if it's a walk, someone will have a scheduled time. But with strength training, they just leave it up in the air. Like, I'm going to get inspired during the week when to do it. It's like, that's not going to happen.
Yeah,
So,
and that's such a good point. And I make it a point with my patients to bring it up each and every time. I find that if I nag them just the right amount of
yeah.
time, at some point, it'll be the right time when they needed to hear it. I
Totally.
have patients who do squats when they brush teeth because the whole day goes by in a rush. So
Totally.
anything that you do at any point in time really helps.
Yeah.
The other misconception that I see when it comes to exercise and PCOS is we think that we need to jog or we think we need to go for a run. It doesn't have to be that way. If you do just plain simple walking, but just move your body any amount that you can every day, it counts. And
Yeah.
people have lost weight and they've kept it off with walking and strength training alone. You don't have
Yeah.
to jog even. You can just walk.
Yeah. I think you know some about my journey, but it's been 6+ years of me just every year working on this. And walking is my thing. It's my jam.
Yeah.
Everyone that listens knows they're probably sick of hearing it. But it's sometimes in my head, as I've lost more weight, I've been like, oh, well, should I jog or should I this or that? Because back in the day in college, I had a trainer and I got to the place of running a few miles, but I hated every single minute of it. But that's what that trainer wanted from me. Then I'll try to do these little running intervals and then inevitably I get hurt and I don't like it. And I'm like, you don't need to do this. The walking is just fine.
Yeah.
I think
And
we forget that. Yeah.
right. And to your point, exercise should feel low stress to your body. I don't want anyone to exercise to the point that they can't work the next day, that they cannot go to school the next day, where their knees hurt so much. Walking really works. You don't have to put excessive strain on your joints. It doesn't work that way. And we want to make it a part of our life so that we see someone has good health 10 years down the line, 20 years down the line. It's not about losing weight in a month or two by trying a super low carb or super low calorie or a keto diet and then regaining that weight.
Yeah, definitely. Any other lifestyle things with sleep, or I know you mentioned stress being a concern as well. Anything else that goes in the lifestyle category?
Yeah, so stress management is key. We have to make stress part of our lives. The solution cannot be escaping stressful situations. We just have to remember that stress will always be a part of our life, but it's in our control. We can choose how it affects us. So stress can be there, but we don't have to internalize it. I discuss stress management with my patients too. And what we talk about is that, okay, if you're in a stressful situation, can you do something about it or it's out of your control? Because we cannot control other people.
Okay.
If it's not something you can do anything about, you just have to let it go, distract yourself with other things, and then you'll find yourself forgetting it.
Mm-hmm.
Sleep is extremely important. A lot of women with PCOS have sleep apnea that's undiagnosed, and it really interferes with their weight loss journey. It causes high blood pressure that is hard to treat, which leads to pregnancy complications like having to need blood pressure medications during pregnancy. So for PCOS patients, it's very important to make sure that if you have sleep issues, you wake up feeling tired or you're falling asleep without wanting to during the day, then you have to get that checked out and make sure that we're not missing obstructive sleep apnea. The other thing that I see often is in terms of endocrine disrupting chemicals. We talk about this a lot. That's another reason not to drink these protein shakes that we get in plastic bottles or
You're
getting
killing me. I
like
know. I've been trying to break the habit, but Fairlife is so good. Okay.
I'm sorry. Like,
No. But wait. Okay. So plastic, right? And I feel like if it's heated, it's even worse. And what other endocrine disruptors do you see commonly?
another reason not to get takeout so often. So all these takeout boxes, plastic, even if it's cardboard, it's lined with plastic.
I know.
So takeout is
Depressing.
maybe once a week just to relax with your family, but it should not be only about the food. It should be about the relaxation. It's about socialization. So All these things really add up. For my patients, especially when they're trying to get pregnant, I make sure that we cover all these things, use glass containers, reheat food in microwaves using glass containers. Don't use all these fragrances and then plug and spray and then fragrance candles, like so much exposure that we don't really need.
I know. I have a stepdaughter that's 14 years old and she smells fabulous, but I'm like, oh my God, this is going to destroy you. How can I broach this topic without sounding like I'm trying to control you, but I care about your future, you know? I don't think people realize all this. I find it really overwhelming because I even grew up in a family where my mom did glass for us with all the things. This was like the physician household. So they were doing all this before we even knew about all this kind of stuff. But I have found that it's like, do you not use a Ziploc bag? There's just so much that I'm trying these things, but it's like really hard. It's more effort, you know, because you got to actually
Yes,
wash the dishes and I don't know, it's harder, I think.
it is hard, but it makes a real difference. So with the Ziploc bags, I was much better about these endocrine disrupting chemicals when I didn't have kids.
Yeah,
But with kids,
that's what
it's kind of
thank you.
impossible avoiding plastics, impossible avoiding all these extra things that just creep up into our lives, right? But it's not that one thing or that two things. It's like, how
Everything.
much better can you do?
Yeah,
And instead of using just hand sanitizers, alcohol, killing all our germs, killing all the bacteria, just soap and water works really well. That's
yeah,
why soap and water for all these dangerous infections that we get in the hospital
yeah,
system, like with the C.
yeah,
diff.
yeah.
So we say soap and water is the best thing, better just to do it as much as possible. And we talk about washing dishes, right? But even those little movements throughout the day, they build up towards increasing our activity levels. And
Yeah.
that helps to just burn more calories in the long run.
I actually have a question still about with endocrine disruptors. So I had someone online ask me, well, how can I tell if it's getting better? How can I tell what's affecting me and if it's getting better? And I'm wondering what your answer is. And can you recheck adiponectin levels? Is there anything that you can actually check to see if it's getting better?
That's a good question, but I don't know much about whether there's actually an objective test. I
Mm.
don't think so, but I think there are a lot of things that we don't know much about,
Yeah.
but we do anyway. So it's just about doing as much as possible in every area. Stress management definitely plays a big role. Endocrine disrupting chemicals, more especially in a woman's life when they're trying to plan a pregnancy, because we want to avoid all those unnecessary exposures. But in terms of objectively measuring, I don't know. But PCOS population specifically, I would say just cycles coming back at regular intervals is a really good sign. So if
Yeah.
someone's periods are coming back at regular, predictable intervals, we can do a day 21 progesterone to see if they're actually ovulating.
Love it. Yeah. It's not so cut and dry as nothing
And
is, right?
right, and the more we study, the more we know, the more we don't know.
That's what I say too. I always say the smartest I ever felt was junior year of high school. I was in AP biology and I was like, I know everything. And then after that, I kept learning, but I was like, I know nothing. I know nothing. So, yeah,
Yeah.
I love that you just said that. I want to shift to talking about what are your thoughts on supplements? Because I think like the minute that PCOS patients are often told this long list, be it like inositol, berberine, you name it. So are there any of these that either you see clinically with your patients or there's actually a good evidence base behind it where you actually do tend to use these things with them?
Yeah, my approach is probably not what we see commonly from other people, just because, for example, with biotin supplements, a lot of people are on biotin for their hair and for their nails, does not work as well for their hair. But with biotin, I see that it interferes with thyroid blood tests.
Yeah.
We know about that, but we don't know about other newer supplements on the market, whether they can interfere with the testing, whether it can interfere with things. And also, supplements don't just come in their pure form. There's always fillers added to it. There's mannitol, there is pectin, and different things are added to that supplement. So it's not as pure as we think the way it looks like on a shelf sitting there with multiple labels on it. So for people with PCOS, I tell them to take a prenatal that is NSF, National Sport Foundation, or US PTF certified, just because we know that prenatals have to be taken 3 months before planning a pregnancy, but even at other times, it can be good as a multivitamin.
Yeah.
So a prenatal vitamin, even if you skip it 2-3 days a week, doesn't matter. At least you've been taking it for a long time. The other thing is we want to make sure we don't miss a vitamin D deficiency. We want good levels of vitamin D because vitamin D is a prohormone, affects helps your other hormones work better too. So with vitamin D, it's important to check levels because I have seen levels of 99, so super high levels too. And when we get into dangerous high vitamin D levels, it can actually lead to bone issues like bone fractures.
So we're talking about someone earlier today, their vitamin D was over 120. And I said, this is an emergency. Like this is immediately, this needs to change. So it's just interesting. I think some practitioners are really pushing the levels. And I get that on the functional land, there could be some variety in that. But then I like that you bring up at some point, it's actually dangerous. Where do you typically like to get it to?
I'm pretty conventional in that. Like 30, I'm happy.
Okay.
30 to 50, I'm happy.
Yeah, definitely. Are there any supplements that you are recommending beyond the multivitamin?
Yeah, ferritin is another thing that I keep an eye on just because it has to do with hair health. And also, if a woman is planning pregnancy, we want to make sure that we replenish her iron stores before planning a healthy pregnancy because we want to avoid complications as much as possible. Whenever a patient comes to me, PCOS or otherwise, but especially PCOS, I ask them what their goals are. And no matter what their goals are, I want to see what their health looks like, or I want them to be at a really healthy level 10 years later, 20 years later. It's not about just 2 months later or 3 months later. Okay, you got pregnant, fine, good for you, congratulations. Because your health during your pregnancy matters, your health after pregnancy matters too.
Yeah.
So because we want to plan your health in the long run, it really matters how we manage your nutrition, how we manage your day-to-day living, how we manage your activity.
Yeah, yeah. I had a coach that I worked with a few years ago, and I was thinking, oh my gosh, this is taking so long. And she was like, Matea, look how young you are. You might have had this 30 whatever years. You still have maybe 60 in front of you. She's like, even if it took you 5, 10 years, it's not an if, it's a when. And once I had that perspective shift, like what you're talking about, the 10 years, I think that's so important because everyone is so narrowly focused on a few months or half a year or a vacation. And it's like, but really, I care that you don't have a bone fracture at 80. That's what I'm invested in for you. You do things a lot differently when you're not so urgency focused. It's actually overall health.
Yeah, and we see that in clinical medicine too, because we see that, sure, you lost weight in the short run with restricting your calories, depriving yourself, but then when you regain that weight back, it actually gets deposited in our organ systems, around our organs, around our liver, and that's actually more harmful to our health in the long run.
Yeah, that's so depressing to me with the regain that you can get back to the same weight, but now you have more visceral fat. It's so sad. I've talked about that because with the yo-yo, people, a lot of the time they want to use a medication short term. And I'm like, that makes absolutely no sense if we're using this for chronic weight management because it's a treatment, not a cure, right? So any other supplements that you use with people?
Ferritin levels, taking a look at their iron level. I like to look at that. A lot of PCOS patients, when they come to me, they're on inositol. If they're on inositol, I don't necessarily take them off of it. But if they do show signs of insulin resistance, which many of them do, most of them do, then I take them off of it and place them on metformin just because it's more regulated. We know what dose works. We know how to up titrate it. And also we know that we can continue metformin until someone gets pregnant, but then I take patients off of metformin when they actually get pregnant, when that test comes back positive.
Okay. Yeah, I was actually going to ask you about metformin, what your thoughts were on that. And by the way, this is unrelated, but you said you do a lot of CGM. Do you have, and we're not like endorsing anything, but do you have a brand where you find it to be more affordable or better quality? Is there one that you typically write for, or is it just what the insurance will cover?
In my experience, both brands are the same. There's no perfect brand, actually. All brands can have a false positive, false negative. Super important to counsel patients that not to get freaked out with a low blood sugar, because especially if we don't do it the right way, if we don't talk to them the right way, as soon as they see that low blood sugar, the machine sends off an alarm and then we're eating like sugary foods,
Right.
So we want to make sure that we tell patients that even someone with normal blood sugars can have a low sugar on a CGM. When I wore a CGM, my blood sugar was in its 40s, but I felt okay. So it depends on how you feel.
So there's not a brand where you typically work with it? No. Okay.
No, I don't recommend a specific brand, but I make sure that I tell them that if you put too much pressure on it, the number can be off. If you get exposed to a very hot shower, the number can be off. But if you do feel symptoms of a low sugar, important to double check with a capillary blood sugar. That's if someone has type 2 diabetes. But if you don't have a diagnosis of type 2 diabetes, just bring it up with your doctor. Don't just eat food if you see a low blood sugar.
Yeah. Yeah. And if anyone's listening, they don't know capillary, she's pointing to her finger. So a blood stick, right? I did wear a CGM, and to me, sleep was so annoying. I tend to be a side sleeper, and I'd be like, it hurts when you're
Yes.
like on that. And then, of course, the readings look wonky because of that. But I loved the knowledge that it gave me, but it made me also like very hypersensitive to, I don't want this to jack it up and I don't want this to ruin it. And while I like the knowledge, I just found I'm so impressed by people long term that can wear it, unless it's like an actual diabetes. But for just a knowledge standpoint, to me, I found more than 2 weeks was just really hard to take on. I don't know if any of
Yeah.
your people find that.
So I actually tell patients to just wear it for 5 days and pay attention to a couple of things. So I want them to pay attention to whether coffee, tea, if they drink that regularly, if that spikes their sugar. Because for some people, even if they drink black coffee, some of us are just more stress prone. I call it sympathetically primed sympathetic nervous system.
Yeah.
So if we're like that, then even black coffee can increase our blood sugar spikes. So that's one thing that I want people paying attention to. I want people to pay attention to when they wake up in the morning. If they're super stressed, cortisol spike, that can itself create a huge spike in the blood sugars. The other thing that I want people to pay attention to when they're using a CGM is if someone does not have borderline diabetes, then your peak blood sugar would not be that high. So if you're seeing numbers in 160s, 170s after you're eating, that probably means you have borderline diabetes or even type 2 diabetes. So we want to know for normal population what the number should look like so you don't miss underlying medical issues.
What is an acceptable peak post meal, like 30 minutes post meal or 15, 30 minutes in there if someone has a normal response?
Yeah, that's an excellent question. CGMs, we don't have that much data in a normal population, but from what I see, it's the change that matters.
Okay.
So for someone with totally normal insulin response to food, probably the change should not be more than 30 points. An ideal person, an ideal glucose response. Let's say if you go all the way from 70 to 130, that's not normal. That means that your body's having to put out excessive amounts of insulin.
Yeah. Yeah. I know that we didn't mean to talk about this, but people ask me so often about it that I'm glad we're having the conversation, because I did the Zoe test back in the day. I don't know if you're familiar with the different cookies and stuff like that. And it was insanity if I did not have the right amount of protein and fiber first, like the food ordering. I mean, it was wild. And so it really helped me realize these morning walks matter so much. The way I'm eating, there was almost no spike at all when I'm eating very balanced, which is that normal to just almost be like flatlined?
This is something that endocrinologists have known about for many, many years. Now there's, with social media, different things trend at different moments, fiber and apple cider vinegar and I don't know whatnot.
Yeah.
But in endocrinology, we have always been telling our patients who need mealtime insulin to eat their fiber and protein first and then eat the carbs. You think of it as layering the tummy. So coat your tummy with fiber, coat your tummy with protein, and then put the carb on top.
Yeah. Yeah. I do that with patients too. And I find some of them, that makes all the difference. Like before even adding a medication, some people already can have a really big response with just that. Do you think there's anything that is like a must know with PCOS that we missed? Because I know we've talked a good amount of time here, but do you think that there's anything else that's important that we didn't touch on?
So if any young females have tried Accutane multiple times, there's probably a undiagnosed PCOS somewhere there. If someone has history of eating disorders, like they feel like they need to restrict their food intake because they tend to gain weight very easily, probably undiagnosed PCOS. Insulin resistance, dark patches, frequent candidal vaginal infections, probably undiagnosed PCOS. It's so common. 1 in 5 women can have it. And the hardest thing for me as a person and as a physician is that it affects women when they're at their most vulnerable age. Our teens, 20s, hard enough, even without PCOS.
Totally.
On top of that, you add in PCOS, self-esteem, self-confidence gets affected. That impacts your academic performance, that impacts your relationships. So if we treat it right, if we diagnose it at the right time, we treat it the right way, you can make better career decisions. You can make better decisions in your relationship choices. This can really impact your life, but we have to diagnose you at the right time. And for that, patients have to advocate for themselves. They have to know what normal periods look like. They have to pay attention to their body. If they start noticing things don't look right, they're growing hair, growing acne, they need laser treatments multiple times, and laser treatments don't work. They're noticing a large part in their hair, bald spots. Make sure that you go get a full checkup, have your blood tests with you, make sure you're not on any hormonal medications before you go get your blood tests done.
Yeah. Oh God, this is so good. Can we just talk briefly about GLP-1s and PCOS? So what do you see there? Is there anything different compared to the normal response that you see?
Yeah, GLP-1s are one tool in our toolbox. Anytime I think about medications, I always want to make sure that someone has access to it in the long run. Mm-hmm. So let's say someone starts GLP-1s and they lose access, because we're talking about very young patients, Yeah. A lot of them are probably carry that diagnosis of type 2 diabetes. Yeah. So my go-to is not GLP-1 just because I worry about their health 10 years down the line. And the worst thing that I can do for them is put them on medication that they won't be able to take a year later, 2 years later. Yeah. So I approach it from that point of view. The encouraging thing is, the really, really great thing is, diet and lifestyle can really make a huge dent. Mm-hmm. So we just have to get people to pay attention to processed foods and marketing strategies that make us make unhealthy food choices. Mm-hmm. Mm-hmm. GLP-1s definitely help, but probably not the best choice in terms of access right now.
It's so sad because it is such a great tool, but I 100% agree with you. If people sometimes, I don't know, maybe it's controversial what we're saying, but it's like they think, oh, you don't want to write it for me, you're withholding. It's like, no, you are actively telling me that you could only afford 2 months of it. That is not helpful. I'm hurting you more than, that's the whole where we took the Hippocratic Oath, right? But it's so sad that even has to be a decision, right? That's something that I always really grapple with our system here in the US.
Yeah, that's why the information you're sharing is so important, because you talk about weight cycling, you talk about how weight cycling is so unhealthy, and that's a real thing. It actually matters.
Yeah. I think people are just so obsessed. We get so indoctrinated that your size needs to be smaller. And I can relate to this. We hear it, it's societal, but then at some point we have to build a stronger belief in our health and what's possible for us. And that's like a hard bridge gap to fill for people. Do you think there's anything else that we didn't talk about? I think we've truly covered all of it.
I think so too, but I find myself coaching my PCOS patients without meaning to. And one thing that I tell my young PCOS patients is that you have to stop listening to what other people say. You have to stop caring about what other people think about you. You just focus on your health, listen to yourself, journal, weight train. Everything else will kind of fall into place.
Oh, I love that you said that. That's such good advice that everyone listening can can benefit from. First of all, just thank you so much for coming on today. I know that everyone's going to have learned so much. Can you tell us what's the best place for people to find you, whether it be social or your website, and just how people can find out more about you?
I'm on TikTok and Instagram as Dr. Sabrina Huq, Dr. Sabrina Huq. And if you Google me, you'll find my clinic. I'm in Broadway, Woodside, Queens, New York.
Awesome. Thank you so much again for taking this time.
Thank you.
That marks the end of today's episode. But if you're newer to the podcast, I want to tell you about something that we have, and it's a free podcast roadmap. So this is perfect for any of you that are listening where you want to be directed to very specific episodes. So let's say that you are just starting out and you want to know, what should I do right when I start on the medications? Or you're experiencing certain side effects on the GLP-1s, or you want to know what to do if you're in a plateau, or if emotional eating is taking over, or if hunger levels are high. So we have many different categories of episodes that we've talked about, because there's a lot at this point. So if you want to be able to navigate that very easily, we have it broken down by category, and also the episodes that are there, and we hyperlink to everything. So you can just click on it and find the episode, easy peasy. If you want that, you can go to rentiaclinic.com/podcast roadmap. We'll have it linked right here underneath the show notes where you're listening. And you can go ahead and get that free resource so that it makes it easy for you to navigate, because I know that it's really hard when someone has an established podcast. I am such a podcast fiend, listening to podcasts all day long. And when I find one that I love, but there's a lot that are out there, I am so lost. So I hope that you enjoy this free podcast roadmap. Again, the link to get to that is going to be rentiaclinic.com/podcast roadmap. I hope this is helpful, and let me know if you have any questions.